I like to introduce Lance Mynderse. He is such a great educator and friend and has an experience in complications, and this is one of my favorite talks. So
it's very appropriate that this follows the regret lecture. My pleasure. Thank you for the invitation to present here. So I have a few disclosures. I think about the process that we look at as sort of a wheel of what I call operational risk. Certainly we're all aiming at that oncologic control, and it's influenced by a number of these other features, the anatomic factors, the energy modalities we use, the safety features of those, and trying to maintain that function. We've heard about this smorgasbord of options. Certainly the thermal ablative types, either hot or cold, those that are non-thermal that we use in regularity, and some others that are being used by our colleagues as well. Each of these has unique safety and features and advantages. Certainly, I think the non-thermal versus the thermal features are part of that. We know that the thermal side of things, a convective and a conductive sort of thing, they all lead to different sorts of side effects profiles. I think the exciting possibilities in the future may be something that's more really cancer specific. None of these others are truly cancer specific. The laser activated nanoparticles and the vasoactive targeted photodynamic therapy, those may have more sort of cancer specificity, but nothing like what we might get with theranostics, which may be something for the future for a focal therapy approach. So in terms of the anatomic features that we have to avoid problems with, I look at these as minefields. Certainly the neurovascular bundles, the urethra, the apex of the prostate, the external sphincter, the rectum, the anterior portion of the posterior aspect of the pubic symphysis. And we don't often talk about the ureter, but if you're going after the base of the prostate or the seminal vesicle takeoff, it's right there. I'm going to use MR-guided cryotherapy to demonstrate some of the problems that we look at and why these are issues. It's got, of course, the great spatial resolution, soft tissue conspicuity. It's near real time if you can do this, if you have a facility to do that. A lot of these same features apply to the ultrasound-guided treatments, but I think the benefits are, we heard about contrast-enhanced ultrasound agents. Certainly the nice things about immediate aspects of post-treatment with MR guidance, you can get the contrast-enhanced images right away. These are some of the MR images of a whole gland and some partial gland cryotherapies. You can see we've got the ability to see things in multi-planes all at the same time. Typically when we do a freezing cycle, it takes about 10 to 20 seconds, and we can watch it grow every 10 to 20 seconds and look at it at the end and watch the thaw as well. In that middle panel, we can see the actual thaw. That's a whole gland salvage after radiation therapy, but you can really see the preservation of the urethra, the urethral warmer, and all the things that we miss after we try to ultrasound through an ice ball, we can see with MR guidance. The mechanisms to avoid injury, of course, we do a lot of things to try to do that. With the urethra, we either try to avoid it with our energy or we try to protect it. We can protect it with warming on the cryo side and heating on the cryo side and warming on the laser side, the other way around. The rectum, certainly to do that, we want to do some things to avoid its proximity to our energy. And you can do the hydrodissection, make sure you have good acoustic coupling so you can see what's there. Neurovascular bundle, a lot of things have been tried. You can heat that area where the prostate is being frozen with cryotherapy. External sphincters, I think this is mainly a planning issue, although some of the non-thermal energies, you may be able to work around the apex much more aggressively without causing damage to the urinary sphincter. Pubic symphysis, I think we often overlook the damage that can be caused there, particularly in large prostates. And if you've got a pubic symphysis issue, they're pretty devastating. We don't always talk about the patient selection on those big prostates that may get us into trouble with urinary retention with many of the things that we do. And then if you're using an access through the skin, think about the damage you can cause to the skin access through whichever way you're going, particularly the perineal skin. So here's some examples of what can go wrong. Urethra. This is a high-intensity focused ultrasound that was done transrectally with an MR-guided treatment. Non-radiated, normal prostate of good vascularity, but this sloughed the whole prostate. And this was a devastating sort of a long-term catheterization. He did recover his voiding function. He did not have any urinary incontinence. We can also see the same sort of thing with transurethral ultrasound ablation. This is the planning two cores that had a clinically significant prostate cancer in the anterior and right side of the prostate. This was the sort of planning we went through with the axial, the DC images, and a sagittal image. And you can see on this next slide the immediate post-GAD defect that we saw encompassing that. But he was a lengthy catheterization, could not urinate, and you can see the damage even with a transurethral approach that even surviving the left side of the prostate, the right certainly caused some problems. Eventually, this went into a slough situation and did well. This is a salvage patient after radiotherapy. The base and the takeoff of the seminal vesicles were treated, and you can see the axial images with a good hydrodissection of the rectum out of the way. You can get some very significant detailing of the cryoablation zone. This is a immediate post. 2 weeks afterwards, we had an MRI, and we saw quite a bit of sloughing, even with the urethral warmer in this patient that was certainly being preserved after radiation as well. But he eventually went on after 4 months to contract that space down, but didn't develop a bladder neck contracture. With a hypocontractile bladder, we resected that bladder neck so he could void again. And this was after radiation, after cryotherapy, and that tissue looks pretty darn good. I would use a resective procedure on this rather than a laser if we're going to do some sort of energy so you do not get further contraction. How about the rectum? Well, this is a devastating complication if you can get these sort of things happen. Certainly we've moved more and more away from our transrectal biopsies, and certainly I think accessing our treatment through the rectum can yield to some issues. This is an example of our laser therapies that we can do through the rectum or the perineum. And this is an example of a treatment aftermath where no rectal fistula, but we certainly have the rectum pulled right up into the posterior aspect of the prostate in the direction that the laser ablation needle performed, and also similarly on a sagittal view. This did not lead to a fistula, but it can. And some of the large series of transrectal laser-activated treatments have a fistula series that goes with it. Many of them recover, but I think if we're looking at this route, we need to look at this as a potential issue. Rectal fistula can happen after cryotherapy. I think with current technologies and imaging, we have it less and less, but it certainly can happen, particularly in a salvage situation. There's some solutions that we have on the MR guidance side of the situation where we can actually hydrodissect with even up to 1 liter of saline transperineally and move the rectum quite dramatically away from the site that you're treating. This is not obviously as easy to do with ultrasound-guided cryo, but you can see there's considerable room that's created here on that. Well, we'll go back here. We can also do it with the salvage places on the biopsy-proven recurrences in the seminal vesicle. Here you can also see the way that we can really almost make the rectum a comma off to the side with all the saline that you push in. And really, if you're working on the seminal vesicles or seminal vesicle bed, you need some room often with the rectum in that location. If you can push it away this significantly, you can really gain some safety margin. What do you do if you get a fistula? Well, there are a number of tools that our endoscopic colleagues in GI have used, the over the scope, in front of the scope, these scrunchies or endoscopic closure devices. They've gotten pretty good at doing endoscopic suturing. This won't work very well in radiated tissue, but there's a number of things that we can sometimes salvage without having to do a full diversion or a proctectomy of that sort of thing. Here's an aftermath of one of such patients. These devices stay in place. They do not get re-epithelialized in many cases, but you can bring flaps down and that sort of thing, which has been done by some of our reconstructive surgeons on the really severe cases. And here's an example of what one looks like after a good repair. There are other promising solutions that we're bringing in from our colorectal colleagues, and this is harvesting stem cells, enhancing them, growing them, using that paracrine effect, the promoting healing, the activated inflamed environment situation where you can really get a tremendous pool of stem cells that you can load onto fistula plugs that are bioabsorbable and plug these into the spaces to make that space close off. And they've had some great successes in colorectal surgery. Pubic symphysis. This is something that I don't think we see very frequently with the imaging that we have, but there are some devastating things that can happen where you can get the osteitis pubis, just the pain-related issues. You can certainly get a number of things happen if you're really treating hard on the dorsum of the prostate and the dorsal venous complex. You get numbness of the penile nerves going down the shaft of the penis, and this urine can track in all sorts of terrible places, through the pubic symphysis, out through the inguinal region, down into the thighs. So in these scenarios, this is a salvage case after radiotherapy, but it can potentially happen if we're not monitoring the aggressiveness of our ablation anteriorly. The ureter, we don't generally think about this, and even with intact prostates, I think we need to look at that. But here is an example of a seminal vesicle bed recurrence that was treated. We stented this. There's two different cases here. The one in the lower right, we put the stent in actually in the MR suite, and we're going to leave it in for a week or 10 days. But the fact that we can see this spatial resolution in MR, we can get with 1 to 2 millimeters of that and still often have good outcomes. So take-home messages, certainly we have to really appreciate the power of each of our modalities that we use for ablation, and each of them will have a different safety profile and consequence on our tissues. I think we've demonstrated some of that in the cases I've shown, and some remedies to really minimize the morbidity. And I just thank you that this sort of treatments inside the MRI scanner involve quite a team. Interventional radiology, MR physicists, all the group that works inside the scanner. This is not an easy place to work, but you can really, I think, have significant reward by doing cases in there. And thank you for the time.
Hey, thank you. I love the documentation. You've done a wonderful job chronologically assessing your complications with beautiful color pictures.
Great presentation. Thank you.